Thank you for joining this webinar presented by the ALS Society of Quebec. My name is Dee Stevens, and I'm a psychosocial counselor here, and I'll be your moderator for the event. Just a reminder, so today we are presenting a webinar on driving and ALS, and it is with great pleasure that I introduce our speaker today, Ms. Kendra Berry. Kendra Berry graduated from McGill University with a Bachelor of Science in Occupational Therapy in 2001 and began working at the Royal Victoria Hospital as an occupational therapist in May of the same year. Since graduating, she has maintained various roles within the McGill University Health Center, including clinical coordinator for the Department of Occupational Therapy. She has worked in both inpatient and outpatient settings and with patients from across various medical disciplines and surgery. She's been working with the multidisciplinary ALS clinic at the Montreal Neurological Institute and Hospital since 2008. So on our website. So without further delay, it is time for Ms. Kendra Berry to begin her presentation. Thank you, Kendra.
So good afternoon. My name is Kendra Berry, and as mentioned, I am an occupational therapist. I've worked as an OT at the MUHC since 2001 and joined the ALS clinic at the Montreal Neurological Institute and Hospital in 2008. In the last 10 years, working with ALS patients and their families, I've really changed not only as a person, but as an OT as well. My OT approach has been about finding function, finding independence, and helping patients achieve their goals. My objective as an OT is to empower patients with a sense of control in an illness that constantly challenges them. In my experience, the three functional activities that patients deem most important and have the hardest time letting go of are mobility, self-feeding, and driving. And of these three, the one that I struggle with most as an OT is driving. It's a very delicate subject and a devastating illness, and I struggle for many reasons. First of all, as a healthcare professional, I have a professional obligation to notify the SAC if I believe that a patient may be unsafe behind the wheel. I have an obligation to protect the patient as well as the general public, and that's a very big and scary responsibility. Second, there are no clear physical and functional guidelines available to determining driving safety from a clinic setting, particularly in patients with ALS. The on-road evaluation remains the gold standard, but there are associated wait times, costs, and can be very stressful for the patient. Third, ALS is a neurodegenerative illness, at times with a rapid progression. It has become easier for us to identify the need for the first on-road, but still very challenging in identifying when a repeat assessment is required. Lastly, and probably the hardest for me, is the amount of importance patients place on being able to drive. It provides a sense of independence, role, identity, self-worth. After one very difficult case involving driving with one of our ALS patients, our team came together and decided that we needed to implement a systematic way of addressing driving with the patients in our clinic, and so the birth of the ALS Steering Wheel. The following is an overview of today's presentation. I will begin by reviewing the Canadian Medical Association driving guidelines, the Société Assurance Automobile du Québec guidelines, forms, and services. I will discuss the results of a retrospective study that we conducted with regards to driving in our clinic, and I will introduce the ALS Steering Wheel with our results to date. The Canadian Medical Association Guide on the Evaluation of Fitness to Drive was first published in 1974. Since its initial publication, it has been revised several times. The 9th edition was released in the past summer of 2017. It's a guide designed to help healthcare professionals, particularly doctors, in counseling patients about the effects of their medical condition on their fitness to drive. Fitness in this context, in the medical sense. In its 7th edition, it recognized a legal ruling that identified the right of Canadian drivers to have their license eligibility determined on the basis of an individual functional assessment rather than exclusively on the basis of a diagnosis. This has an important impact for our ALS patients. Patients often assume that once they are diagnosed, they must stop driving. For this reason, they are often reluctant to notify the SAC of their change in medical status. ALS patients are able to continue driving as long as their functional and medical status allows them to do so safely. According to the guidelines, all doctors should be aware of their responsibility and legislative requirements to report patients with medical conditions that may make them unsafe to drive. The provincial licensing authorities have the final responsibility in determining driving eligibility, but the doctor's recommendations on fitness to drive are very important. In Canada, all doctors have a statutory duty to report patients they believe unfit to drive. In 3 provinces, Quebec, Nova Scotia, and Alberta, reporting is not mandatory, but rather discretionary. In all provinces and territories, doctors are protected from any legal action brought against them for reporting a patient in good faith. They are expected to educate on the impact of the illness with respect to the ability to drive, to identify medical conditions or associated deficits that may deem a patient unfit to drive, and notify the proper authorities if there are concerns. If undecided regarding fitness to drive, doctors should consider arranging consultation with appropriate specialists, for example, an occupational therapist for a functional evaluation. Currently, there is insufficient evidence to recommend for or against any specific type of testing. The on-road evaluation remains the most effective form of testing. I will now review sections of the guidelines that have some pertinence to patients with ALS. In terms of medications, immediate contraindications for driving are medications that cause drowsiness, visual blurring or changes, impaired coordination and movement, or changes in behavior or thought processing. With all new meds, patients should be advised not to drive until their individual response is known or side effects no longer result in impairment. The 9th edition saw the addition of the use of medicinal marijuana. For cognitive impairment, patients with mild cognitive impairments should have on and off-road testing in specialized centers. Patients with moderate to severe cognitive impairments are contraindicated to driving. A moderate cognitive impairment is described as the loss of one activity of daily living, like dressing, feeding, or bathing, or the loss of more than 2 instrumental activities of daily living, like meal preparation, finances, or house cleaning. No test, including the mini-mental, has enough sensitivity as a single test to determine driving ability. However, abnormalities on paper-pencil tests like the mini-mental, the clock, and the trail-making beat should trigger further in-depth ability. Drivers with a mild loss of muscle control can have adaptations. If a condition is progressive, it must be followed closely and discussed when driving is no longer safe. If the condition is also characterized or accompanied by cognitive impairment, patients should likely be advised to stop driving. Any condition that has an impact on physical function may have a negative impact on driving. They require proper assessment in order to determine driving safety. Safe driving requires that both hands be firmly on the steering wheel and the use of the lower extremity to operate the accelerator and the brakes with sufficient speed and force. In terms of respiratory status, there are 3 levels of impairment ranging from mild to severe. Moderate to severe impairments with supplemental oxygen at rest should have a road test with their supplemental oxygen. The rule being the equipment must be secured safely. In the case of ALS patients, this equipment would more than likely be a BiPAP machine. The Société Assurance Automobile du Québec is our driving authority. According to the SAC, driving is a privilege and not a right. All costs with maintaining a license are at a driver's expense. Providing false and inaccurate information to the SAC could lead to the suspension of one's license and a fine of $300 to $600. The SAC must be notified of any medical conditions and or change in medical status prior to obtaining a license at the moment of renewal or within 30 days of a change in health status. It is important to note that the SAC and the SAC alone can issue, suspend, and cancel a driver's license. Our roles as healthcare professionals is to make recommendations on fitness to drive. The SAC recognizes 5 healthcare professionals in recognizing or declaring a patient unfit to drive. They are the doctor, the nurse, the OT, the psychologist, and the optometrist. Included on the inaptitude form are 2 articles, 603 and 605. One stating our responsibility within our field of expertise for declaring a patient unfit, the other stating our protection for having declared a patient in good faith. The doctors and the OT's roles with regards to driving are very similar. While the doctors are determining fitness to drive in a medical sense, OTs are determining fitness to drive in a functional sense. Both have roles in educating patients on the potential impact of the illness on driving safety, identifying deficits that may impact driving safety, directing patients to the appropriate resources, and discussing possible cessation of driving. OTs in specialized centers are able to identify adaptations to promote safe driving. In some provinces like Quebec, these adaptations can be subsidized. There are several ways to declare the diagnosis. One can be on the renewal form of the license, contacting the SAC by phone or email, visiting a SAC service center, or even requesting an adapted parking. It is important to note that once a declaration of change of medical status is made, the SAC will send a medical form called the M28. This form needs to be completed by a doctor. It's a global medical profile form that is 4 pages long. On the last page, question 11, is the doctor's recommendation with regards to driving. Does the patient require a non-road test with the SAC, a non-road test with the OT? Is consultation with a specialist required? And lastly, should the patient stop driving until they are evaluated? 2 other forms may also be sent by the SAC. They are the M5 or the M57. The M5 is a visual examination performed with either an optometrist or an ophthalmologist. The M57 is a functional evaluation road test with a certified OT. This OT evaluation can be done in a rehab center or done privately. Patients must be aware of associated fees when doctors are completing these forms. The costs are at the patient's expense. I always encourage patients to make copies of these forms for their personal records. The handicap parking sticker is issued by the SAC. The eligibility criteria are any persons with a handicap involving loss of autonomy and compromised safety and health when mobilizing over short distances. In order to obtain the sticker, a form must be completed by a designated healthcare professional. These healthcare professionals include an occupational therapist, nurse, physiotherapist, doctor, optometrist, psychologist, or a special educator in the healthcare network. Once the form is completed, it must be sent with a check to the SAC. Once accepted, the patient will be sent the sticker and an attestation certificate. Both of these documents must remain with the patient when using the sticker. The sticker is assigned to the patient and only the patient, whether they are driver or passenger. The patient must be present when it is being used. The patient with the disability must leave or board the vehicle while the car is parked in the reserved space. Also very important is when being used, the parking sticker must be visible in the windshield. There are 2 types of conditions that qualify for stickers, conditions that are either permanent or temporary. In the case of permanent conditions like ALS, the renewal for the parking sticker is every 5 years. In requesting a parking sticker, a diagnosis must be included on the form. If the SAC is unaware of the ALS diagnosis, they will become informed once the form is submitted. The patient will then more than likely receive an M28. The adapted parking sticker is recognized internationally. European countries, Australia, Canada, US, Japan, Korea, and New Zealand allow disabled motorists to use designated handicap parking spots with their respective stickers. The sticker must be visible, and most of the above-mentioned guidelines also apply. The PAV program. The PAV program is the Programme d'Adaptation de Véhicules. It's a program managed by the SAC. The goal of the program is to provide patients that have significant or persistent deficits the ability to access their vehicle and, if a driver, continue to drive safely. In order to be eligible for the program, the patient must have the handicap from birth due to illness, aging, or accident that is not driving related. Patients must be residents of Quebec. They must not reside in a healthcare network facility. They must also not be benefiting from another program that could provide a similar service. Vehicles that are eligible for adaptations include cars, SUV, and minivans. The type of car will depend on the patient's need. that will be identified by an OT evaluation. The PAV program renews every 5 years, so the car must be 5 years or younger or deemed in good condition. Leased vehicles can be adapted, but permission from the dealership is required. The process of pursuing the PAV program involves having forms completed, a medical certificate is required, as well as an occupational therapy evaluation. Once the OT recommendations are made, two estimates from recognized suppliers are required. Once financing is approved, the adaptations can begin. Once complete, an OT verification and training may be required. If cessation of driving is required, there are available resources. One of the most commonly used alternate means of transportation is adapted transport or transport adapté. There are several different transport networks that we see around Montreal. They include the STM, the Société de Transport de Montréal, the STL, the Société de Transport de Laval, and the RTL, the Réseau de Transport de Longueuil. Admission criteria are limitations in activities by significant or persistent incapacity, as well as mobility limitations that include the inability to mobilize over 400 meters on flat ground safely, the inability to climb a 35-centimeter step with a support, the inability to descend a step without support, the inability to use public transit safely, decreased orientation to time and space, or the inability to communicate verbally. There are several advantages to using the adapted transport. Reservations are fairly easy to do. They can be done by phone or online. They usually only need to be done 24 to 48 hours in advance. It is possible to request accompaniment. It is not expensive. It usually works with a ticket or on the Opus card. There are reduced fares for patients that are 65 and older. Patients in wheelchairs can avoid transfers and can ride directly in their wheelchair. And on days of difficult weather conditions, it is often easier for both the patient and the caregiver. There are disadvantages as well, mostly related to convenience. There may be delays in pickups and drop-offs. There also may be destination and network limitations in terms of time and destination restrictions. There are community resources that vary across the different communities, ranging from volunteer services to low-cost transport. The CLSC should be able to provide patients with a list of these local resources. As another option, patients can proceed with the PAV program to adapt their vehicle as a passenger. Patients also can purchase used or already adapted vehicles, or they can be rented. For the final parts of this presentation, I will be discussing how driving is addressed with the patients followed in our ALS clinic at the Montreal Neurological Hospital and Institute. As mentioned earlier, driving is a very delicate subject from both patient and healthcare professional perspective. A few years ago, we made the realization that we did not have a systematic or consistent way of addressing driving with our patients. As a first step, we conducted a chart review of 15 patients followed in our clinic between April 2005 and October 2015, in which driving had been addressed. What we learned was patients were not advised of the responsibility to notify the SAC of the new diagnosis. Driving was not always discussed early. Some patients were followed for more than a year before driving was ever addressed. Adaptations were underused. Only 1 out of the 15 patients had their vehicle adapted as a driver, whereas we identified a potential 10 of the 15 that may have benefited from adaptations to prolong driving safety. The triggers that we were also using for on-road evaluations were very varied, so they ranged from cognitive deficits, presence of a foot drop, hand weakness, weakness in the shoulders, the use of the BiPAP day-night, none of which were consistent. So our next step was performing a lit search for assessments that we could use in our clinic to assess the patient. One study that was of interest was the Maryland Pilot Older Driving Study. It was a project that had as its goal to identify at-risk drivers with low-cost testing. 6 of the 9 tests it used were identified as having predictive value for drivers at risk of crash. With statistical analysis, they were able to identify 2 types of cut points: prevention and intervention. intervention cut point indicating that further examination like an on-road test was required. So what are the challenges in our clinic? Well, first of all, many of our patients drive. Some are caregivers, sole drivers, patients with young children, still working. It's a delicate issue. There is no good time to discuss driving. As the illness progresses, the team is constantly addressing new issues. Driving is also often addressed by the doctor and the OT. And in the context of our clinic, given the volume and different clinic days, it's not always addressed in a consistent manner. Patients often come to clinic with long problem lists and pressing issues, and driving risks not being addressed. This just reinforces the need for multidisciplinary involvement. Patients are also not consistently declaring their diagnosis, mostly from fear of losing their license. And from experience, it seems that the patients with the cognitive impairments are easier to identify for being at risk for safe driving. What's more difficult is identifying physical component thresholds. For example, what grip strength is needed to hold the steering wheel firmly? What lower extremity strength and coordination is needed to move from gas to brake with sufficient speed and force? So what we needed was a systematic approach that could be applied to all the patients in our ALS clinic. We were looking at improving the quality of the process, but also the care that was being provided. We needed to be in keeping with the CMA and SAC guidelines. It needed to be multidisciplinary. With the context of our clinic, it was necessary not only to ensure care was consistent, but also to better support the patients. We needed to have something that was quick and easy to administer. And we needed to find and establish guidelines of when to refer patients for on-road evaluations and/or adaptation. The beauty and strength of our ALS clinic is the multidisciplinary team. The concept of the steering wheel came during one of our brainstorming sessions in the conference room. In the center of the steering wheel is the patient, surrounded by the members of our team. Our goal is to address driving in a client-centered manner, allowing patients to be decision makers, respected, informed, valued, and empowered, and each one of us has a role to play. So our action plan is to steer the patient, to support the patient. It's imperative that patients feel supported throughout the entire process, from initial diagnosis to the eventual cessation of driving. We don't want patients to ever feel ambushed or confronted. Our goal is really to ensure the smoothest process possible. From the documentation and articles read and in services that we attended, tracking violations, near misses, crashes, and self-regulating driving behaviors are all important red flags. Educate, also very important. Educate, providing education on the impact of ALS on driving, the patient's responsibility to the SAC, the team's responsibility to the SAC, the options for on-road evaluations, whether they be public or private, the possibility of adaptations to prolong driving safety, eventual cessation from driving, as well as options for alternative means of transportation. Evaluate. It's a neurodegenerative illness. We need to closely be monitoring medical, functional, physical, cognitive abilities that could compromise driving safety. And lastly, refer. When indicated, refer the patients for on-road evaluation. So the components that we're looking at take into the account the complexity of the ALS diagnosis, as well as the guidelines set forth by the CMA. So the medical, physical, cognitive, functional, and socio-spiritual components. This is a sample of the worksheets that we use to evaluate the patient. The evaluations that we chose target each of the identified component areas. Most evaluations are done at each visit, with the exception of the cognitive screens, which are performed at every 6 months. We retained 7 of the 9 tests used in the Maryland project, which used the GRIMS battery. To that, we added a questionnaire, review of medication, their MRC dyspnea scale, which is the scale used on the M28, the ALS FRS, the ALS CBS, and we also added grip strength. So this, you can see, is the worksheet that we have. You see there is different team members that are able to perform the test, as well as the indication of the cut point. Implementation process. So we began the implementation of the ALS Steering Wheel in September 2017. Prior to its implementation, there were several meetings with the team to review the questionnaire, the assessments with the prevention and intervention cut points, as well as the overall process. In the morning rounds before clinic, patients requiring screening are identified. A blue folder with the worksheet is attached to the patient's ALS file as a visual reminder for team members. In the event of a patient requiring screening that was not identified, extra blue folders are available from the clinic coordinator. At the end of the clinic, the files are brought back together and the results are tabulated. The results, the identification of cut points, are discussed in rounds the following week, at which point the team makes their recommendation. If an on-road evaluation is required, the doctor will complete the M28 and the OT will refer the patient for the assessment. Since September, we have addressed driving with 54 patients. Of the 54 patients, 7 stopped voluntarily, 3 stopped involuntarily, and that was at the recommendation of a healthcare professional, and 44 were screened using the ALS steering wheel. 29 of the 44 patients were referred for on-road evaluations, and this meant that they were identified as having more than two prevention cut points or more than one intervention cut point. As of September 2018, 16 evaluations had been completed. When patients are identified as needing an on-road evaluation, a referral is made to a public rehab center that has a driving evaluation program. The wait times can range from 3 to 9+ months. This wait time was problematic for us for several reasons, but mostly because it was compromising our attempts of being proactive. It risked placing us in a position of reactivity with the potential of hindering our attempts to want to prolong driving safety. Given that the wait times with the private OT was less than 2 weeks, it was decided that all of our patients requiring on-road evaluations would have a dual referral. They would be referred to a rehab center with the option of having a subsidized private OT evaluation. The advantage of the private referral is that we could immediately assess driving safety as well as begin the process for minor adaptations if indicated. As of September 2018, 12 patients had undergone private on-road evaluation. So what does a private on-road evaluation look like? Well, a private on-road evaluation is performed with a certified private OT and a certified driving monitor. The monitor provides the vehicle for the test, which can either be standard or automatic. Prior to the road test, the OT will perform an interview, evaluate physical cognitive components, and do a mise en situation in the patient's own car to assess the patient's manipulation of primary and secondary controls. As per SAC requirements, the road test includes variation of speed, familiar and non-familiar environments, non-protected left turns, as well as circulation in rural and non-rural areas. The driving evaluation includes assessment of operational, tactical, and strategic skills. So as of September 2018, 9 of our 12 patients passed their on-road evaluation with the private OT. These are some of the recommendations that we saw post-evaluation. Conditions were added to licenses, which included the need for an automatic transmission, power steering, and anti-lock brakes. Future adaptations were identified, but in none of the cases were they deemed necessary. The evaluations provided us with a time frame for reevaluation, which varied from 3 to 12 months, which seemed to correlate with the extent of the physical deficit. And in one of the recommendations was that a patient increase their frequency to keep the patient fluid with their driving. One limitation that we did encounter with the private evaluation is when patients had extensive upper or lower extremity weakness and required an on-road, they needed already adapted vehicles that were only available in the rehab centers, therefore they could not be done privately. In the rehab centers, we've had 3 patients undergo evaluations, 2 of the 3 passed, and 2 of these patients had adaptations to their vehicles as drivers. Reflection. So in the first year of this quality improvement project, what have we seen? We've seen multidisciplinary involvement. in identifying patients that are driving, participating in screening, providing patients with education, as well as contributing to team recommendations. The integration into our clinical practice has been quite easy, even in our busiest clinic days. The beauty of the complete screening is that it's separated and assigned to different team members. As an OT, I've noticed that addressing driving with these patients is much easier, and I think it's for many reasons. First, early intervention, we're addressing it right away. There are never any surprises. The holistic completeness of the entire assessment, the identification of having cut points is allowing our team to make educated recommendations. Multidisciplinary involvement is promoting consistency in evaluating, providing information, and supporting patients. And I think it's been very helpful to be able to provide patients with a funded private evaluation. Another advantage that we've noticed is that technology in our newer cars is compensating for physical limitations. So this includes the push-button ignition and parking brake, automatic lock, sensored wipers. These are all reducing the need for adaptations and are promoting independence in our drivers. In 2 of our patients that did not pass their driving evaluations, private evaluations, both had significant upper extremity weakness, but also had a significant element of fatigue and limited endurance. And this is an element that we haven't captured in our assessment, but I think looking forward, it is something that we will add. In our driving questionnaire, one of our last questions is, what does driving represent to you? I was surprised and amazed with the unanimity of the answers. All patients equated driving with autonomy. One patient even stated that driving was his only significant activity that he could perform independently. The magnitude of these answers just reaffirmed what I already knew: the importance that driving has for our ALS patients, and the responsibility that we have as healthcare professionals to try to make this happen. So what is our hope with this? Our team was given a grant from ALS Canada to run this quality improvement project for 2 years. Our hope is that we get smarter, that we find a sustainable process and tools that can improve our way of addressing driving with ALS. It's an opportunity for the different team members to develop their expertise in contributing to the steering wheel. What is presented today is just a proposed framework, something that we're hoping to develop until this project is complete. We hope to identify tests that are useful in predicting the results of on-road tests. We also hope to show the necessity of reducing wait times for on-road evaluations, public rehab centers for our ALS clientele. We hope to see increased use of adaptations that have the potential for allowing patients to prolong their driving ability. Most importantly, our biggest hope is to promote and prolong driving safety in ALS patients. Our hope is to give patients a sense of function, independence, and control. So just as a closing note, we've now hit full-blown winter. So here are a couple of little driving tips from the SAC. They have a video on their website. This is a summary. So when driving in winter to promote safety, first of all, clean your car to ensure proper visibility. So make sure you take off all snow and ice. Important is keeping a safe distance with the car in front of you to allow yourself enough time to react. When it's dark, ensure your lights are on. Also, patience is a virtue. Please remain patient with the motorist in front of you, beside you, as well as snow removal operations. And what I will add to this is, as important as these driving must is getting to and from your car safely. Use your parking sticker, plan ahead, prioritize, use the recommended mobility aids recommended by your physio and OT, have somebody accompany you if possible to and from your car, and make sure you have your cell phone. So there's a couple of thank yous that I want to put out there. First of all, to the ALS Quebec for allowing me to come here today. To ALS Canada for believing in our project and allowing us to run it for 2 years. A very special thank you to Christiana Salmon, who, no pun intended, is the driving force, my partner in this project, as well as the ALS team at the Montreal Neurological Hospital.
Thank you very much, Kendra, for this very informative presentation. Just before we move